Bismillahirrahmanirrahim. Assalamu alaikum. Third year class MBBS. Hope you all students will be fine. Today's topic is female sex hormones. The gonadal hormones include the steroids of the ovary and testes. Steroids of the ovary include estrogens and progesterone, and testes, the chief major hormone is testosterone. Due to their importance as contraceptives, many synthetic estrogens and progestins have been produced. These include synthesis inhibitors, receptor antagonists, and some drugs with mixed effects. That is, some drugs have mixed effects. That is, these drugs have agonist effects in some tissues while antagonist effects in other tissues. Mixed agonists with estrogen effects are called selective estrogen receptor modulator or SERMs. Synthetic androgens, including those with anabolic activity, are also available for clinical use. A diverse group of drugs with anti-androgenic effects is used in the treatment of prostate cancer and benign prostatic hyperplasia in men and hyperandrogenism in women. First of all, classification of drugs, gonadal hormones, agonist and antagonist. Estrogens, for example, athenyl estradiol in anti-estrogens include receptor antagonists, and in receptor antagonists further classified as full antagonists, which includes fulvestrants and SERMs. SERM are selective estrogen receptor modulators, which have agonist action at some tissues while antagonist action in other tissues. Example of SERMs includes tamoxifen. Next is aromatase inhibitors, which includes anastrozole, and next is other gonadotropin releasing hormone agonists, which include danazol. In progestins, the major example is norgestrel, and then antiprogestins, which include mifeprostone, and in antiprogestins, which further classified as receptor antagonists, which include flutamide, and then 5-alpha reductase inhibitors, which include finasteride. Then finally, synthesis inhibitors, which include ketoconazole. Ovarian hormones. The ovary is the primary source of gonadal hormones in women during the childbearing years, that is between puberty and menopause. When properly regulated by follicle stimulating hormone, that is FSH, and luteinizing hormone, that is LH, from the pituitary, each menstrual cycle consists of the following events. A follicle in the ovary matures, secretes increasing amount of estrogen, releases an ovum, and is transformed into a progesterone secreting corpus luteum. If the ovum is not fertilized and implanted, the corpus luteum degenerates. The uterine endometrium, which has proliferated under the stimulation of estrogen and progesterone, is shed as part of menstrual flow, and this cycle repeats. The mechanism of action of both estrogen and progesterone involves entry into the cell, binding to the cytosolic receptor, and translocation of the receptor hormone complex into the nucleus. And in the nucleus, it further regulates or modulates the expression of genes. Follicle stimulating hormone, luteinizing hormone, and FSH and LH analogs. They are pituitary hormones. In women, FSH or follicle stimulating hormone directs follicle development, whereas FSH and LH collaborate in the regulation of ovarian steroidogenesis. The gonadotropins and their analogs are used in combination to stimulate spermatogenesis in infertile men and to induce ovulation in women with an ovulation that is not responsive to less complicated treatments. All ovulation induction protocols that use gonadotropins have three basic steps. Now, there are three basic steps which I tell you one by one, which involve the ovulation induction protocols. First, androgenous gonadotropin production is inhibited by the administration of gonadotropin releasing hormone agonist or antagonist. Then, secondly, development of follicle is driven by daily injections of preparation with FSH activity, which include minotropins, FSH or FSH analog. Minotropins include FSH hormone. Last, the final stage of oocyte maturation is induced with an injection of LH or the NLH analog human chorionic gonadotropin. A variety of gonadotropin preparations are available, all are administered parenterally. And now, one by one, I will discuss the aminotropins. These gonadotropin consist of mixture of FSH and LH purified from the urine of postmenopausal women who produce high levels of FSH and LH owing to the disinhibition of pituitary gonadotropin production that results from cessation of ovarian steroidogenesis. The next, FSH and its analogs, three forms of FSH are available. Urofolitropin is a purified preparation extracted from the urine of postmenopausal women. The two recombinant forms of human FSH, folitropin alpha and folitropin beta, they differ in the composition of their carbohydrate side chains. LH and its analogs, human chorionic gonadotropin, the placental protein that supports a corpus luteum during the early stages of pregnancy, has a structure that is nearly identical to LH and mediates its effect through the activation of LH receptors. HCG is purified from human urine or recombinant HCG is also used commonly for an LH activity. Lutropin, another recombinant form of human LH, is also available. Now the next is hypothalamic hormones. Gonadotropin releasing hormone is a decapeptide that stimulates gonadotropin release when it is secreted in a pulsatile pattern by the hypothalamus. Leuprolide was the first of a set of synthetic peptides with long-acting gonadotropin releasing hormone agonist. In man and women, steady dosing with these gonadotropin releasing hormone agonists inhibits gonadotropin release by down-regulating gonadotropin receptors in the pituitary cells that normally release gonadotropins. Continuous gonadotropin releasing hormone agonist treatment is used to suppress endogenous gonadotropin secretion. In these cases, these underlying cases is used to suppress the gonadotropin secretion in women undergoing ovulation induction with gonadotropins and continuous gonadotropin hormone agonist treatment is also used in women with gynecological disorders that benefit from ovarian suppression like endometriosis or uterine leiomyomata. Continuous gonadotropin hormone agonist treatment is also used in men with advanced prostate cancer, in children with central precocious puberty. In women, continuous treatment with gonadotropin releasing hormone agonist causes the typical symptoms of menopause. It may cause the typical symptoms of menopause like hot flashes, sweats, and headache. Long-term treatment, therefore, should be avoided because of the risk of bone loss and osteoporosis. Ganirelix, cetrorelix, and dagarelix are gonadotropin-releasing hormone antagonists. Ganirelix and cetrorelix can be used during ovulation induction in place of gonadotropin-releasing hormone agonists to suppress endogenous gonadotropin production. Dagarelix is approved for the treatment of advanced prostate cancer. The adverse effects of gonadotropin release hormone antagonists are similar to those associated with continuous treatment with the gonadotropin releasing hormone agonists. Next, estrogens. The major ovarian estrogen in women is estradiol. Estradiol has low oral bioavailability and estradiol is available in a micronized form for oral use. It can also be administered by a transdermal patch, vaginal cream, or intramuscular injection. Estrogens, long-acting esters of estradiol that are converted in the body to estradiol, can be administered by intramuscular or IM injection. Mixtures of conjugated estrogens from biological sources, for example, pre-marine, are used orally for hormone replacement therapy. Synthetic estrogens with high bioavailability, like ethinyl estradiol, mestranol, are also used in hormonal contraceptives. Now, the effects of estrogen. Estrogen is essential for normal female reproductive development. It is responsible for the growth of genital structures, vagina, uterus, uterine tube during childhood, and for the appearance of scanty sexual characteristics and the growth associated with puberty. Estrogens has many metabolic effects. It modifies serum protein levels and reduces the bone desorption. It enhances the coagulability of blood. It increases plasma triglyceride levels. It reduces low density lipoprotein cholesterol and increasing high density lipoprotein cholesterol. Continuous administration of estrogen, especially in combination with the progestin, inhibits the secretion of gonadotropins from the anterior pituitary. Now, the clinical uses of estrogens. Estrogens are used in the treatment of hypogonadism in young female. Another use is a hormonal replacement therapy in women with estrogen deficiency resulting from premature ovarian failure, menopause, or surgical removal of ovaries. Hormone replacement therapy prevents hot flushes and atrophic changes in the urogenital tract. It is also effective in preventing bone loss and osteoporosis. The estrogens are components of hormonal contraceptives. Now, the toxicity of estrogens in hypogonadal girls, the dose of estrogen must be adjusted carefully to prevent premature closure of epiphyses of the long bones and short stature. When used as hormone replacement therapy, estrogen increases the risk of endometrial cancer. This effect is prevented by combining the estrogen with progestin. Estrogen use by postmenopausal women is associated with a small increase in the risk of breast cancer and cardiovascular events like myocardial infarction and stroke. Dose-dependent toxicity include nausea, breast tenderness, increased risk of migraine, headache, thromboembolic events, gallbladder disease, triglyceridemia, and hypertension, hypertriglyceridemia. Diethylstilbestrol, a non-steroidal estrogen compound, is associated with infertility, ectopic pregnancy, and vaginal adenocarcinoma in the daughters of a woman who were treated with the drug during pregnancy in a misguided attempt to prevent recurrent spontaneous abortion. These effects appear to be restricted to diethylstilbestrol because there is no evidence that the estrogens and progesterone in hormonal contraceptives have similar effect or other teratogenic effects. Next hormone is progestrins. Progesterone is a major progestins in human. A micronized form is used orally for hormone replacement therapy, and progestin containing vaginal cream is also available. Synthetic progesterone include medroxyprogesterone, have improved oral bioavailability. The 19 nortestosterone compounds differ primarily in their degree of endogenic effects. Older drugs like norgestrel and norethindrone are more androgenic than the newer progestins like norgestimate or desogestrel. Effects of progesterone. Progesterone induces quickly changes in the endometrium and is required for the maintenance of pregnancy. The other progestins also stabilize the endometrium but do not support pregnancy. Progestins do not significantly affect the plasma protein levels, but they do affect carbohydrate metabolism and they stimulate the deposition of fat. High doses suppress the gonadotropin secretion and often cause an ovulation in women. Now, the clinical uses of progestin. Progestins are used as contraceptives either alone or in combination with an estrogen. They are used in combination with an estrogen in hormone replacement therapy to prevent estrogen-induced endometrial cancer. Progesterone is used in assisted reproductive technology methods to promote and maintain pregnancy. The toxicity of progesterone is low. They may increase the blood pressure. They may decrease the HDL level. Long-term use of high dose in premenopausal women is associated with a reversible decrease in bone density, a secondary effect of ovarian suppression and decreased ovarian production of estrogen, and delayed resumption of ovulation after termination of therapy. Now, anti-estrogens and anti-progestins. Selective estrogen receptor modulators. They have mixed estrogen agonists that have estrogen agonist effect in some tissues and act as partial agonist or antagonist of estrogen in other tissues. So they have got selective estrogen receptor modulator. They have got both effects. In some tissues, they act as agonists of estrogens or partial agonists, and at other tissues they act as antagonists of estrogens. Tamoxifen is an example of selective estrogen receptor modulator. Tamoxifen is a selective receptor estrogen modulator that is effective in the treatment of hormone responsive breast cancer, which acts as an antagonist to prevent receptor activation by endogenous estrogens. Tamoxifen is also used as a prophylactic use of tamoxifen reduces the incidence of breast cancer in women who are at very high risk, and it's also an agonist of endometrial receptor. So it is an act as agonist at endometrial receptor. So it promote endometrial hyperplasia and it may increase the risk of endometrial cancer. So this drug also causes hot flashes. This is the antagonist effect, increases the risk of venous thrombosis. This is agonist effect of estrogen. Tamoxifen has more agonist than antagonist action on bone, and thus it prevents osteoporosis in postmenopausal women. Torimifene is structurally related to tamoxifen and has similar properties, indications, and toxicity. Next selective estrogen receptor modulator is raloxifene. Raloxifene is approved for prevention and treatment of osteoporosis in postmenopausal women. It has a partial agonist effect on bone. Like tamoxifen, raloxifene has antagonist effects in breast tissue and reduces the incidence of breast cancer in women who are at very high risk. Unlike tamoxifen, the drug has no estrogenic effects on endometrial tissue. Adverse effects include hot flashes, which is an antagonist effect, and increased risk of venous thrombosis, which is agonist effect. Next drug is clomiphene. Clomiphene, what is clomiphene? It is a non-steroidal compound with tissue selective action. It is used to induce ovulation in an ovulatory woman who wish to become pregnant. By selectively blocking estrogen receptors in the pituitary, clomiphene reduces negative feedback and increases FSH and LH output. The increase in gonadotropin stimulates ovulation. Now, next classification is pure estrogen receptor antagonist, which include fulvestrant. It is a pure receptor antagonist in all tissues. It is used in the treatment of a woman with breast cancer that has developed resistance to tamoxifen. Next, synthesis inhibitors, which includes aromatase inhibitors, anastrozole and related compounds like letrozole are non-steroidal competitive inhibitors of aromatase. Aromatase is the enzyme which is required for the last step in synthesis of estrogen. Exemestane is also an irreversible aromatase inhibitor. These drugs are used in the treatment of breast cancer. Next drug is danazol. Danazol inhibits several cytochrome P450 enzyme involved in gonadal steroid synthesis. Danazol is a weak partial agonist of progesterone, androgen, and glucocorticoid receptors. Danazol is also sometimes used in the treatment of endometriosis and fibrocystic disease of the breast. Next is gonadotropin releasing hormone analogs and antagonists. In this category, leuprolide is included. Continued administration of gonadotropin releasing hormone, gonadotropin releasing agonist, suppresses gonadotropin secretion and thereby inhibits ovarian production of estrogens and progesterone. The gonadotropin releasing hormone agonists are used in combination with other agents in controlled ovarian hyperstimulation. This is your assignment. What are selective estrogen receptor modulators? Write down clinical uses and adverse effects of tamoxifen. Now the gonadotropin releasing hormones analogs and antagonists. It is used for treatment of precocious puberty in children. It's also used for the short-term treatment of endometriosis and uterine fibroids in women. Treatment beyond 6 months in premenopausal women can result in decreased bone density. The gonadotropin releasing hormone receptor antagonists ganirelix and cetrorelix are used for controlled ovarian hyperstimulation. Next is antiprogestins, which is mifeprostone. It is an orally active steroid antagonist of progesterone and glucocorticoids. Its major use is an abortifacient in early pregnancy. Up to 49 days after the last menstrual period, the combination of mifeprostone and the prostaglandin E analog misoprostol achieves a complete abortion in over 95% of early pregnancies. Antiprogestins, the most common complication is failure to induce a complete abortion. So side effects of morpheprostone include due to the include nausea, vomiting, and diarrhea, plus the vaginal cramping and bleeding associated with passing the pregnancy. Rarely, patients who use morpheprostone and misoprostol for medical abortion have experienced serious infection, but these are rarely, but this may happen, like sepsis and even death due to unusual infection due to Clostridium sordieli.